Good morning, everyone. Thank you, Corey, for asking me to give this talk today. There's a small but growing cohort of us oncologists who are dual trained in hospice and palliative medicine, and this is a topic that's near and dear to my heart. And I think about this all the time, and I talk about it certainly with patients and families. So no financial disclosures for me. So I think we can all agree that in thoracic oncology and in advanced cancer in general, the burden of symptoms is really high for our patients. They are often dealing with a lot of psychosocial, spiritual, and existential distress. Numerous studies have shown that the quality of life for these patients is pretty poor at the end of life. And often these patients receive very costly and resource-intensive care at the end of life. So in thinking about sort of what is palliative care? The Center to Advance Palliative Care, which is a national member-based organization to promote knowledge about palliative care and increase the uptake of these services nationwide, sort of defines palliative care as specialized medical care for people with serious illnesses, very simply put, not just for cancer, but for end-stage heart disease, COPD, HIV, and a multitude of other diseases. And so this type of care is aimed at providing relief from the symptoms, the pain, and the distress of these diseases, no matter the diagnosis. So in thinking about sort of the practical applications of palliative care, it's an interdisciplinary specialty, probably the most interdisciplinary specialty in medicine. It's not sort of an MD focused team, but rather MDs, nurses, social workers, chaplains, spiritual support providers. And the goal is to prevent and relieve suffering, and also to enhance quality of life, not just for patients, but really to support the whole family as they're going through the trajectory of illness. So the basic skills required of people who provide palliative care are basic pain and symptom management, sort of advanced communication training about goals of care, prognostic awareness, and really trying to help coordinate care over time and specifically focusing on transitions in care, particularly at the end of life. I think importantly, it's really important to stress to our patients that palliative care is appropriate for anyone facing a serious illness, and it certainly is not mutually exclusive with curative intent therapy. So the purported benefits of palliative care are that it reduces the symptom burden of our patients, it reduces depression, it improves quality of life, and it increases satisfaction with care. And certainly in 2 trials, there's been data to show that it prolongs survival, although I think that's pretty controversial, and I'm really curious to see what future trials show. And certainly there's the idea that we can help decrease burnout among providers who are dealing with sick and dying patients all the time. So when we think about primary versus specialist palliative care or secondary palliative care, primary palliative care is really provided by everyone in this room who takes care of advanced cancer patients. So it's basic symptom management and communication with our patients. Specialist palliative care is defined as that provided by people who have undergone extra training in hospice and palliative medicine, and certainly do a little bit more advanced pain and symptom management as well as advanced communication. So when we think about sort of the old model of palliative care, I think many of you have probably seen this schematic. We sort of do disease-directed therapies up until the time at which no further chemo or other therapy is possible, and then we used to sort of call in palliative care to assist with end-of-life transitions, and that would be sort of a very brief period before death, and then sort of the aftercare of the family. So based on evidence from numerous trials, and I've certainly only highlighted a couple here, I think the TEML trial from the MGH group is probably sort of the most well-known. They took 151 patients and randomized them with metastatic non-small cell lung cancer and randomized them to 2 arms. One, the standard arm being sort of usual palliative care, where the oncologist referred the patient to palliative care when and if appropriate, versus the early palliative care arm, where they were sort of identified within 6 weeks of diagnosis and had recurring visits with a palliative care provider until death. And so in this trial, the primary endpoints were quality of life and mood, and certainly there were significant improvements in both of those, but surprisingly, the trial actually showed a survival benefit of 3 months, sort of an overall survival benefit, which one could argue is as good as many of the therapies we offer our patients. And so hence this was published in the New England Journal of Medicine in 2010, and I'm going to go into a little bit more detail sort of what happened to these patients at the end of life in terms of the type of care that they received. There was another trial published more recently in The Lancet where they took patients of with many different advanced cancers and randomized them again to early palliative care consultation and follow-up, similar to the TEML trial versus just standard care. And again, in that trial, there were significant improvements in symptoms, quality of life, satisfaction, but not in overall survival. And then the Bakitas group from UAB performed sort of a nurse-led intervention, which is a psychoeducational phone intervention for patients in rural New Hampshire and Vermont who otherwise wouldn't have access to specialist palliative care services. And this intervention actually yielded improvements in mood and quality of life, but not symptoms. So I think based on some of this evidence, we now accept that probably the way we should be integrating palliative care is early on in the course of disease, and a patient may need more or less palliative care throughout the trajectory. But certainly it should be an integral part of care from the very beginning. And when we think about models of palliative care, Eduardo Bruera, who is sort of a pioneer in supportive oncology at MD Anderson, sort of has categorized the way we deliver palliative care in 3 ways. I've only shown 2 of the models, the first model being a solo practice model, which is how a lot of palliative care is delivered in the community where the oncologist is doing palliative care alongside standard oncology care. I think the model on the left, the Congress practice model, is the way palliative care has typically been used as a consultative service primarily to deal with end-of-life issues. The integrated care model, I think, is sort of an ideal that we're trying to strive for, certainly at our cancer center, where we really view ourselves as part of the team that's integrating in with cancer care early on, and then we sort of consult out for invasive or intensive therapies, but certainly we sort of see ourselves as part of the care team from the beginning. So when we think about integrated palliative care, ASCO recommends that we combine standard oncology care and palliative care early in the course of disease for all patients with metastatic cancer. This poses multiple challenges simply because of the availability of services. Over half of cancer centers simply don't have outpatient palliative care to offer their patients, and certainly that number is even lower in community settings. Other barriers to palliative care include sort of family and patient perceptions of what that may be, that it's only appropriate at the end of life. Issues with reimbursement are certainly an issue. It's a pretty low reimbursed specialty, and it's a time-intensive. These are often time-intensive visits. And certainly there are concerns that if you're referred to palliative care, that means that you have to give up disease-directed therapy. And certainly there's a shortage of fellowship-trained palliative care providers nationwide. So when we think about the barrier of palliative care being equated with hospice care or end-of-life care, this schematic is really just to show that while hospice is a part of palliative care, it by no means is sort of all of what palliative care can do. So just to outline sort of the differences between palliative care and hospice care, again, palliative care can be offered at any time during the disease course, regardless of prognosis, and patients still have access to all disease-directed therapy, whereas hospice care is a Medicare benefit for patients whose providers estimate that they have a prognosis of 6 months or less, and it does require cessation of disease-directed therapy, so that's certainly a shift in goals of care. So when we think about what hospice care provides, it certainly helps to manage pain and symptoms largely in the home setting, provides support to the caregivers and education to the caregivers, medical equipment and other supplies that the family might need. Certainly there's inpatient hospice care available, and then importantly for 13 months after death, they provide bereavement care and counseling. So when we think about who to refer to palliative care, in 2011, CAPC put out a consensus statement with primary and secondary criteria. The surprise question is one that I really like, basically saying, would you be surprised if this patient died within 1 year? And I'm going to talk a little bit more about data on that question. And certainly people who are being admitted over and over again for frequent symptom management or pain crises, people who are declining markedly in terms of their functional status, and people who require complex care should be considered for referral. And then the secondary criteria aren't specific to cancer per se, but certainly sort of are markers of debility and people who are at a high risk of death. The NCCN last year put out guidelines for sort of palliative care screening, and these are the criteria that they have sort of outlined as important. And I think in that, I think life expectancy less than or equal to 6 months is great if we can sort of define who that population is. Certainly, we're seeing more and more requests by patients and families who are requesting palliative care consultation because they may have read an article about it or watched a frontline documentary about it. So we're certainly seeing more and more requests driven by patients and families. So at the ASCO Palliative Care Symposium last month, there was a really neat study published by or presented by the group at Dana-Farber when they're sort of trying to think about which patients would benefit from palliative care. So they took 76 oncology providers, the majority of whom were physicians, but also nurse practitioners, and they asked those physicians to look at a group of almost 4,800 patients, and they asked them, would you be surprised if this patient died within 1 year? So for about 4,000 of those patients, those providers said, yes, I would be surprised, and for a smaller number, they answered no, and then they looked at these patients over the course of a year. Impressively, the hazard ratio for patients whom the providers had said, no, I wouldn't be surprised if this patient died within a year was almost 10. So that's pretty notable. However, the sensitivity was only about 60%, so that certainly limits its utility as a screening tool, as a sole screening tool. But I think, sort of your gut of who's going to die within 1 year should be taken into a sort of multimodal assessment of who would benefit from palliative care. So another critical question is sort of when to refer, and I think there's certainly a growing body of evidence to say that early referral is probably better. However, if that doesn't happen and you're meeting a patient later in the course of disease, I try to think about these critical clinical decision points at which we should think about referring patients to palliative care. So that's at the time of disease progression is certainly a time to sit down, reevaluate goals, prognostic awareness, and think about palliative care referral. When patients are experiencing significant progression in symptoms, and certainly at sentinel events, which I see often happening in our patient population when they have ER visits or hospital admissions. And certainly patients who you identify are struggling with decision-making about whether to get the third line of chemotherapy or not. So traditionally, palliative care, again, has been very late in the course of disease, really emphasizing acute symptom management and sort of putting out fires in terms of symptom crises. And when we think about sort of beyond, just improved symptom control and quality of life improvement in the early palliative care trial, I'd like to focus on the health resource use piece. So in a secondary analysis of the early palliative care trial, the interesting results were that there was lower IV chemotherapy use at the very end of life, however, better survival and better uptake of hospice services. And we'll talk about that a little bit more. So this is a secondary analysis of the TEML trial from MGH. So the top panel there looks at the total number of chemotherapy regimens in the two arms of that trial, the standard versus the early palliative care. And you can see there are no significant differences between the number of chemotherapy regimens these patients received. However, when you look at the panel A on the bottom, in terms of IV chemotherapy, the early palliative care group received significantly less chemotherapy within the last 2 months of life, yet had better survival. So I think that's an interesting finding. There were no differences in the rates of oral chemotherapy use. And when we look at hospice use, although there's similar proportions of patients received hospice care, there was a greater or longer length of stay in the patients who received early palliative care. And that's actually an ASCO COPI measure, so I think it's an important one to sort of follow going forward. So one question that I've heard Diane Meyer, who's a pioneer in palliative care, often ask is, what is in the palliative care syringe? Have we really identified what it is that results in these improvements in quality of life, satisfaction, and mood? So surely we think that attention to symptom management, the psychological and cultural and existential aspects of distress certainly help. I think that promoting illness understanding, prognostic awareness, and helping patients to feel informed and promote a shared approach to decisions has to make a difference. I certainly think we need more data on what actually happens in an outpatient palliative care visit that really results in these differences. So from the same palliative care trial published by TEML in 2010, there was a secondary analysis. This was a qualitative study looking at the themes that emerged in palliative care visits over the trajectory of someone's disease. And they identified 7 key themes, and you can see on the right here, end-of-life planning was really only but one theme that emerged. And certainly addressing coping, illness understanding, symptom management, and discussing the cancer treatments was as important, if not more, than just talking about end-of-life planning. They looked at the differences between how oncology providers and palliative care providers spoke to patients and the themes that emerged at critical clinical time points. And these time points were basically at disease progression or with clinical deterioration in terms of symptoms. And so when we looked at early, middle, and late visits, palliative care providers early on tended to focus a little bit on prognosis, but a lot on relationship building and information preferences, figuring out how patients learn about illness and how they want to receive information. In the middle of the trajectory of illness, they focused on symptoms and coping and engaging the family, and again, addressing illness understanding. And then it's really only late in the course of disease that end-of-life care planning really came up in these visits. And when we look at the differences between oncology and palliative care providers, the light gray bars are oncologists, whereas the dark gray are palliative care providers. We can see that at critical clinical decision points, oncologists tend to focus more on cancer treatment and discussing and managing medical complications, which makes a lot of sense. And palliative care providers tend to focus a little bit more on coping and relationship building and supporting families. So we could argue that it really sort of takes a team approach to address the end-of-life care needs of this patient population. So the conclusions, I think, from that study are really that palliative care visits employ a semi-structured but flexible approach. And we found in that study that both oncology and palliative care providers address end-of-life care planning. And that the optimal timing of discussions, I really think early on, it's about building rapport and discussing prognosis. And really, once you've established a relationship, it sort of paves the road to talk about end-of-life care planning at disease progression. And so the conclusions I hope you'll take away are that palliative care is really appropriate for any patient with advanced cancer who's facing a high symptom burden, a lot of distress, and difficult decision-making. Certainly that hospice is but one component of palliative care, but that palliative care is much more than hospice care. And certainly there's a growing body of evidence for early palliative care in advanced cancer. Thank you.